Sounds great.
All right. Well, it is 9 o'clock on the dot, so we will get started. Good morning. How's everybody doing today? It is June 23rd. Hope everyone had a great Father's Day, celebrating dads as best as we can during this COVID time. Mine is in a retirement community that's not allowing people to come see him. So at age 94, he pretty much spent it alone, which breaks my heart. So that's one of the negatives about what's going on during this pandemic. And anyway, he had several phone calls and he got through the day, but it's just one of those things that we're dealing with during this time, the summer of 2020. So thank you for attending the Telemedicine Echo. The Heartland Telehealth Resource Center and Missouri Telehealth Network have partnered together to bring you this Project Echo for telemedicine. And we'll cover things like technology, operations, clinical flow, legal, regulatory, and evaluation. And we're going to touch on a lot of those today, actually, from MU Healthcare. So we're excited to bring you this topic today. I'm Janine Gracie, Project Director for the HTRC, and I have the honor to moderate these sessions for providers in Missouri, Kansas, and Oklahoma. Before we get started, though, I'd like to ask everyone on this Echo, if you've not done this before, to make sure that you have your first and last name and state abbreviation on your picture or on your little square. And the way you do that is that you right-click and hit rename on that little pull-down menu and make sure that you have your name and your state so that we can appropriately identify you as well as know what state you're from. So thank you for doing that. And while you continue to do that, we will have team members introduce themselves on the hub. So we'll start with Evelyn today.
Good morning, great to see you all online. I'm Evelyn Nelson. I'm a telepsychologist in Kansas and also the PI for the Heartland Telehealth Resource Center.
Thanks, Evelyn. All right, Rachel.
Hi, everybody. Rachel Mutra from the Missouri Telehealth Network, the Show Me Echo program, and the Heartland Telehealth Resource Center. Welcome.
Wonderful. Thank you, Rachel. Robert.
Hi, I'm Robert Stiles with the University of Kansas School of Medicine and provide assistance to the Heartland Telehealth Resource Center as well.
Tim.
Good morning, Tim Davis, Telehealth Manager at Oklahoma State University Center for Health Sciences in Tulsa, and the Oklahoma rep for HTRC.
And last but not least, Heather.
Good morning, everyone. My name is Heather Hagan. I'm a telehealth analyst at OSU CHS in Tulsa.
Wonderful. Thank you, Heather. Karen Edison can't be with us today, but she's also a member of the Hub team. I'm sure that she'll be back next week. All right, so we are nearing 30, and when that happens, we just don't have enough time to go through and introduce everyone. So please use the chat to provide your first and last name, the state you're from, your organization, and your position so that we can get to know you that way. And it allows us just to better have, an idea of who's on and what your position is and what your responsibilities are so that we can understand that. Thank you for joining. And phone, let's see if we have any phone. Don't see anybody on the phone, so we're good there. All right. Well, now I have just a few announcements. For a more collegial environment, we use first names only during our Project Echoes. Really want to make sure that we're conscious of confidential or protected health information. So if you're sharing a case study or if you have a question, just make sure that we don't share that kind of information with everyone. If you have questions, it's great if you would go to the chat and hit the down arrow under to, where it says, usually it says to everyone, Then you go down and see Ask Joe Kingsbury, and he can collect questions during our presentation, and then we'll make sure that to get to those questions after the didactic. So please use the Ask Joe Kingsbury for questions that you want to type out. Now, this is not stopping you from asking them live. So, you know, you don't have to type them. You can just remember what it is that you want to ask the presenter, and then we'll get to those after the didactic. So listen, we want your questions. We do not want you to leave this echo with unanswered questions. Let's see here. When it's time for you to ask those questions, just kind of raise your hand, keep your microphone on mute until you're ready to speak, and remind participants, I need to remind you that you need to provide your name. Just tell us your name before you ask that question. Presentations and case studies are on Box. If you have difficulty getting on that box, please let Lauren know, or myself. We'll help you. We've been able to help navigate some folks through that process if you're unfamiliar with it. Listen, the value of the Project Echo is in the case studies. And so if you want to present a case study to this Echo, please, by all means. It may be a little different than the Echoes that you have participated in before, but a case study could be, hey, we're having problems with a platform, and we're wondering if anybody else is having these problems, or, you know, a case study about reimbursement, that type of thing. So please think about what you would like to ask, and we'll go through those, because that is where the real learning takes place. All right. So now let's turn to the didactic. Carey Ruckberg obtained her bachelor's and master's from Stevens College. She holds an MBA. She's the virtual care manager at MU Healthcare, where she's responsible for leading and managing all clinical, technical, business, and regulatory activities of that program. Wow, that's a big job. She's going to discuss the impact of COVID-19 and the MU Healthcare's response to rapidly adopting telehealth throughout their system. So I'm very curious to hear Carey. So I'm just going to let you take it away. Carey, it's all yours.
Great. Well, good morning, everyone. Thank you so much for having me. I'm super excited to share kind of our, as we said, rapid journey to adopting telehealth and virtual care throughout our system. Again, I work at the University of Missouri Health System in Columbia, Missouri. And we've been doing telehealth for several years. And actually, Rachel Mutro and her team with the Missouri Telehealth Network have been facilitating telehealth and working with rural communities, as well as establishing echoes throughout our state for several years. But when we started looking internally, there was a lot of work to be done around how we were interacting with our patients in direct care, and how we could leverage virtual care. And I use the term virtual care. You know, telehealth is a term that I'm sure most of you are familiar with, and we did use that for quite a time. But we're really trying to look at the full picture and broad scope of really what virtual care is, which encompasses so many different types of interactions that you can have with a patient. So I'm going to go ahead and share my screen with a brief presentation that I've put together today, and then feel free to, again, ask any questions as we go along. Let's see here. Are you all able to see that? Okay, great. So again, just to set the stage again, virtual care is really that broad term that encompasses all the ways that healthcare providers can interact with patients. And the types of virtual care that we do at MU Healthcare, we do e-visits, so portal messaging. We have on-demand 24/7 access to providers for low acuity care, so what we call our urgent care platform. We do provider consults, inpatient treatment and monitoring for high acuity care. And then we've also got a variety of scheduled telehealth, so direct to facility where a patient is coming for a follow-up visit, or video visits, which really is that direct to patient in a home or non-medical facility. And also in response to what we did with COVID, we set up a lot of telephone visits, with audio only, because there actually is quite a bit of reimbursement currently related to audio only interaction with patients. And then, of course, remote patient monitoring, which some of you may be familiar with, data that's captured through wearables or other devices that can be transmitted back into our electronic medical record. So talking specifically about what we did in response to COVID. So obviously COVID came along, came quickly, and we weren't probably thinking all of the ways that we could respond virtually. And quickly we learned that there was lots of ways. So we actually we work with a variety of different vendors for telehealth platforms, but one of our contracts that we had currently was with American Well, which is a pretty well-known established telehealth or virtual care solution. We used our platform that we had to develop a free COVID-19 video visit practice where we allowed community members and patients of our system and really anywhere to access those free visits for pre-screening with some of our providers, as well as supplemental coverage by American Well's online care group. Our emergency medicine group was the primary owners of that platform or that practice. We saw over 3,100 patients through that over the course of 3 months. And we recently turned that off with the low, well, I should say was low, but starting to kind of pick back up in our area of COVID-related cases. But we still offer our virtual urgent care platform, which is specific to low acuity care that can be treated virtually. So we're talking about, eye rash, things that allow providers to actually visually see the patient, but not physically have to examine. And then certainly when we have patients that may come onto that platform and need in-person care, we then refer them to, whether it's the emergency department or urgent care location to be physically examined in person. We also rapidly expanded Zoom video visits. We didn't historically use Zoom for direct-to-patient care, but with lots of the freedom around conducting virtual care and with the already existing Zoom relationship that we had from the University of Missouri campus, all of our employees and staff had access to a Zoom account. So all of our providers, all of our PSRs, everybody that was a part of our whole entire university system had access to a Zoom account, which made it really easy for all of us to work together to massively deploy and start putting together documents and protocols on how we would actually interact with patients utilizing Zoom technology. So that's not obviously something that's new. Zoom was primarily in our system used for meeting purposes like we are today, but was also a great way, and we had a HIPAA compliant version of Zoom to be able to massively deploy that out to our patients who were able to download that technology to be seen. And I'll show in a slide here shortly how rapidly that expansion and the number of visits that we did occurred, but primarily use Zoom technology for our patients that were in our ambulatory care, so outpatients that were either at home or another non-medical facility. And then a lot of folks also being in rural Missouri, we always have a challenge of patients having access to broadband, or sometimes they may not have the means to actually utilize a cell phone or another type of device to connect with us. So we utilize telephones and visits to be able to be reimbursed from our provider side for some of that care that was really just to check in and make sure that those patients were still being taken care of when we couldn't physically bring them in. And a lot of this was really great because, again, it kept a lot of patients outside of our system at a time where we really didn't want them walking into clinics, potentially exposing other patients, exposing our staff and providers, and really help keep really COVID at bay so that we didn't have those challenges with PPE and some of the other issues that a lot of other health systems were facing across the nation. One of the other unique things we did was we set up iPads in our emergency department, our MICU, so medical intensive care, in our surgery intensive unit, where we had patients who may have COVID or were suspected of COVID. And so we would want to communicate with them without necessarily having to gown or have a provider go in and out of that room several times. So to reduce exposure and save and conserve PPE, we utilized iPads to communicate with those patients that were in those rooms. So that was a unique way that specifically addressed the issue with COVID and some of the things that we were trying to contain from either cost as well as exposure to our staff and providers. And then we started also doing a lot of telehealth to some of our skilled nursing facilities. So utilizing Zoom and some of the other technologies that were approved to facilitate to those locations where, transferring patients from those locations is difficult to begin with, but then you're worried about exposing them to COVID or other, respiratory illnesses where, really we went into those skilled facilities, provided care, and additionally did some testing for them on site because we didn't want them to have to go through our drive testing facility to be tested if they were suspected of potential COVID. So a lot of great work with our emergency medicine team to kind of help facilitate a lot of that initiatives. And so certainly the way we were able to expand so rapidly was because of a lot of the relaxation around reimbursement from federal and commercial payers. So CMS, of course, came out with a lot of flexibility in this time to be able to provide that care as well as be able to get reimbursement. So what we were able to do is, utilize and actually promote the use of virtual care throughout our system because now it was reimbursable. Where one of our biggest challenges prior to COVID was getting physician buy-in. Having them figure out where this fits in with their workflow and their clinics, how do they utilize the technology, and when we really had to focus with no other option but to look virtually, we had a lot of success with getting people on board to start providing that care. And on top of that, they were then getting reimbursed for doing it. So we're hopeful, well, we know probably that landscape's quickly going to change when we go back to kind of what is the new normal, I should say. But what we're hoping is that some of that information or those regulations will stay where reimbursement is achievable for some of that lower acuity or follow-up care that we can be providing to patients. And then, of course, the ability that we already had Zoom protected environment and a relationship with American Well let us, be able to utilize what we currently had existing within our system to, quickly promote and be able to utilize those resources. And then we really used a collaborative team approach. We worked really well with our ambulatory leaders to figure out how we were going to massively deploy and train our staff to be able to provide virtual care. A lot of these clinics had never done virtual care. They may have used Zoom once or twice, but they were not used to on a regular basis scheduling patients and sending things through our portal, which is again where we communicate with our patients, in a lot of different ways. What was also great is thinking through all the things that we had to think from a compliance standpoint. So, our notice of privacy practices, and if we were going to be seeing a patient that was brand new to our system, making sure that they had a consent for treating for services. So thinking really as a full picture and involving all of these different areas, whether it was IT, compliance, legal, our ambulatory leadership, really our command center for COVID specifically on how we were addressing, some of those free video visits and how we were communicating with our drive-through testing site to get those patients to be screened. There was just a lot of team approach to getting that to be a success. And it felt very good from my area to feel supported. Again, virtual care and telehealth have always had a place at our system, but really until COVID happened, I would say, I always joke that I'm about 10 years behind where I wish I had been in high school, that popular girl that everyone turned to and wanted to have some help. Certainly didn't have that in high school, but now everyone seems to know that virtual care is here to stay and that we're, forming a team to really help continue to reach our patients when it's, crucial to their care as well as quality. So that was super exciting. And then just by the numbers, I think obviously this highlights pretty significantly the amount of virtual care that we were conducting, on a fiscal year, and our fiscal year runs July 1 to June 30th. And so obviously you can see we were doing some virtual care or some telehealth. A lot of that was actually through some, again, the connections that Rachel and her team had done historically with Durham and some of our other programs at rural communities as outreach. But again, we weren't doing a whole lot direct to the patient at home or really figuring out how to make that work within our own ambulatory clinics. And as you can see in FY20, and I would probably have broken this out a little bit better for you to see the different, specialties that are now offering this. I think we're at about 144 different specialties that are offering virtual care or did at some point during COVID, where in the prior years we were at about 9 to 10 different specialties. So certainly a huge uptick in the number of clinics and specialties that are offering that. And one of our biggest ones, which makes a whole lot of sense, was our family medicine departments. So they historically, weren't offering virtual care. Now they're doing the majority and are actually the leaders in offering that. Which makes a lot of sense. A lot of what they see is for follow-up or for, checks like med reconciliation for ADHD or some of those things that don't require that physical examination, but are really there to be added touch points with the patient. So that's great to see that really those clinics have embraced that. And so again, 47,000 visits that we have, and combined with what we've done from our American Well platform for direct to the patient, whether it was through the COVID-free visit screenings or if it was through our virtual urgent care. And then lastly, as we look forward, we're really trying to go to more of a centralized model. So a lot of this has been really fragmented. So of course, we've got groups doing different things, and we're trying to get everyone to kind of come together to use best practices and to figure out what's the right technology, what's the appropriate place and when to do virtual care. We realize obviously not every specialty can do this. You do need some of that physical examination to occur. And so what is the right specialty? What is the right place within our clinics to allow this, as well as thinking through resources. So do we have enough webcams, and do we have enough computers that will allow our providers to facilitate this type of care? Obviously, when we didn't have patients coming in, there was lots of space to conduct virtual visits, and there was a lot of privacy because no patients were in our clinics. But as that shifted back and we start seeing more patients in our system come in person, we have to be cautious of being in a private setting and making sure that we're adhering to all the things that we need to adhere from a virtual perspective. So a lot of this is moving to really this centralized best practice. How do we get everyone on the same page going forward? And then certainly continuing to monitor reimbursement, compliance, and privacy in relation to virtual care. A lot of that obviously is dictated by CMS and what the federal government comes out with. We're obviously constantly looking to see how that's shifting and changing, because we want to make sure that what we're providing has an ability to be reimbursed, or there's a benefit to why we're doing it. So we think about sometimes also not just reimbursement, but some of the downstream effects that virtual care can have as far as, readmissions or some of the areas where, unnecessary transports of patients can be utilized to help reduce costs internally. So certainly trying to figure out what is the best model for that as well. And then really working to employ or implement really an embedded video solution with our EMR. So having really that seamless experience for the provider, the patient, and the staff. So if I'm a provider and I'm going into the EMR and I'm looking at my patient's chart, having a way to actually launch the video from that patient's chart so that everything is in one space and I don't have to log into a separate, platform or Zoom account to launch that visit. It's really embedded within our system. And from the patient perspective, going to the portal or some other place that we've identified as really the front door to communicating with our patients. And that's kind of, as you see, the revamp of our MU Healthcare's digital front door, which is kind of a new buzzword out in the marketplace as far as how do we interact with our patients virtually, whether it's through billing, whether it's through, checking kiosks and, all these different varieties of ways to virtually communicate. And then again, expanding, virtual care services. So looking outward, how do we help our community hospitals and other rural areas? How do we partner with them to provide specialty care that they may not have? And how do we also gain, if we don't have those services as well? So working internally and externally to identify what we need as an organization to continue to provide care to Missourians. And then I think the biggest thing, and I know Rachel definitely has a lot of experience in this, is understanding how do we get access to broadband and how do we help our rural communities that don't have this great coverage to be able to provide that type of care to the patient. What do we do to partner with our extensions offices? What do we do to figure out other ways that patients can utilize community resources such as the library or other places to really gain the ability to access that care when at their home they may or may not have that connectivity. Sorry. So that's really all I had to share for today. I'm happy to take any questions. We're constantly evolving, and we have got a great relationship with Rachel and the Missouri Telehealth Network. They continue to be a wonderful resource and have lots of knowledge and experience, and certainly have been a mentor to me as I've kind of embraced this, newer role for our health system. But we're super excited to keep pushing it forward and figuring out how do we make this really a part of our system and not so much just a, added luxury. So.
Thank you so much, Carey. What a wonderful presentation. And I tell you, you're probably exhausted after all of this urgent deployment of telehealth and getting everybody on board. So good job. So now we will open it up to questions, and I'm going to start with Joe to see if any questions have come through the chat.
Well, thank you, Janine. There are no questions in the chat currently, so I think we could probably just open it up to the floor.
All right, let's do that. Does anyone have, okay, Rachel's got her hand up, so I'm going to call on Rachel.
Carey, I have a question. We've had lots of discussions in this group about how patients react to telehealth, and I wonder if you have any of your survey data back that you could share with us.
We haven't really done a whole lot of surveys with our ambulatory clinics with the utilization of Zoom. I know we try to use a net promoter score indicator to identify when our patients are coming to clinics, what they really feel about the care they're receiving. And I know we're looking to incorporate some of that to be virtual. I will say from our American Well platform and what we've done direct to the consumer from that side, we have a really high success with patients enjoying utilizing that. We actually find that they enjoy the provider interaction with our own providers as well as the online supplement coverage. They usually rate us at about a 4.8 out of 5 is the average. And then with our system, it's a little bit lower. I think it's with the system of the platform being the solution, it's about a 4.7 out of 5, which is still pretty high for most of what we know based off of what American Well tells us as indicators. So hoping to incorporate more of that as we go forward, though, because we certainly want to make sure that however we're providing care, we have a baseline of understanding how patients like that and are receiving it.
Great, thank you, Carey. Joe?
We have a couple of questions that are rolling in. First one, how has your switch increased telehealth? I'm sorry, how does your switch to increase telehealth affected your previous no-show and late cancellation rates?
That's a great question. I think we are still trying to swift through some of that. Historically, when we were providing virtual care on a really limited basis, we didn't see a huge difference in no-show rates among virtual and in-person. But I will say that we certainly had patients indicate that if we didn't have a virtual offering, they would have just canceled and not connected with our providers over the course of COVID taking place. And so certainly we're trying to understand too, if there is a direct correlation between being able to reach a patient virtually versus having the only option to be coming in person. A lot of the benefits to providing that virtual visit too, even outside of COVID, is the time that it takes for a patient to be in person versus what they can do virtually and how they can conduct that virtual visit at a more convenient time. We think about a lot of the patients that travel, sometimes even from Springfield area, that take 3 hours or some hours to get here, spend a couple hours waiting to be seen, and then have a 5-minute interaction with a provider just to go home. And so certainly one of the things I can share too, and let me see if I can get it pulled up here, is a telehealth dashboard that we've created that allows us to track based off where the patient's located by zip code, the amount of miles avoided to actually be computed back so that we're saving miles for our patients that otherwise would have had to come in person for that visit. So I'll try to pull that up here real quick. It also has some data around who's our highest age group of utilization, which was actually really surprising. You would think with the generation of the millennials and those that use a lot of technology to begin with and grew up on it would be the primary focus, but we actually saw quite a bit of our baby boomers and other types of generations utilizing virtual care much more predominantly than we probably would have expected. So let me just see if I can get that pulled up, but feel free to ask questions while I work on that.
Sure. While you're pulling that up, have you gotten provider resistance?
Not as much as I would have expected. I think because our providers got as much as we could to train. So we did a lot of trainings. So we focused on creating documents and really easy processes, well, as easy as we could, to get them up and going. I would say that, we've historically had a lot of physician resistance, but when this was really the only way to keep in touch with our patients and ensure that we were still trying to connect with them, we felt that a lot of our providers were able to accept and actually embrace that change, which was a really nice benefit to what COVID actually did. As sad as it is that a pandemic kind of took that role to really embrace it. I think what it's done is it's shown a lot of our providers who may have had resistance prior to COVID that this is a way that you can provide care. And you just have to identify what's the appropriate use of it. Again, not every specialty can provide that type of virtual encounter, but if you think a lot of our pre and our post-op surgery, follow-ups, things that again require just a 5-minute, no hands-on interaction with a patient, those are the really great opportunities to connect with them and provide those type of virtual encounters.
Perfect, thank you. Next question that came in. How many or what percentage of patients had to use the phone versus video because of lack of broadband, cellular service, or data?
I'll be quite honest, I don't know the exact percentage on that. I'm going to say, though, quite a few. I would say that we did struggle with having patients. And I don't know so much if it was, I want to say the majority of it was because of the location that they were in and they didn't have that. It also can be that the fact that a lot of these communities don't, these patients in these communities don't have a cell phone that has a smartphone or some type of technology or a laptop that actually allows for the video component. But I would say broadband is a continual issue that we have in rural Missouri that, again, always presents challenges. Even when we've got patients that feel really comfortable utilizing technology, they may run into struggles with connectivity just because of where they are merely located, which is a huge issue and continues to be a limiting factor for us to actually expand virtual care to those in those communities.
Perfect, thank you. Next question for you. If you knew then what you know now, what would you have done differently? And as you move forward, do you plan to change the program?
I don't think I would do it differently because I think it allowed us to see where the gaps were within our program. I don't think until you're put into a position where you have to kind of full force embrace what you've got and try to figure out how to make it work, does it allow you to really understand where you may lack in your program or where you may be really successful and you didn't realize it. And so I think for me, I'm glad that I've had that experience. While it was causing a lot of heartburn and some sleepless nights, I would say it certainly provided an eye-opening experience to figure out how do we make things more efficient and how do we help leverage this so that we can make a difference. Thinking again about not always just reimbursement for telehealth, but how can our system use this as a cost-saving benefit? How do we avoid some of those transmission or transfers or readmissions where we could provide an added touch point to that location where the patient is before they have to be readmitted, before they have to be transferred back, and really think about how does our system save around some of that. And so I think going forward, I think it's learning and looking back on what didn't go great and how do we increase, awareness of how we pursue that and going forward. So I wouldn't take it back. I think I might, think of other ways that we could have been creative. I think we did as much as we could with the amount of time that we had to respond, much like I'm sure many of you on this call did. And so certainly, I think as we go forward, just trying to learn from those experiences and figure out how do we continue to make this, again, a more centralized approach going forward, because certainly we don't want to be very fragmented in our approach going forward, because then we start seeing, people be less engaged, patients and providers frustrated with some of the, gaps, and we need to just figure out how to kind of hone in on that so that it's a good experience for all involved.
Next question for you, Carey. Any suggestions for offering telehealth visits to patients without seeming like it's the only option for the patient and they don't have the option to come into the office?
Yeah, and so I think it's twisting it. So, certainly we understand that some patients just don't want to do virtual encounters, and that's completely fine. I think what we did was we are here for you, whether you doing it in person or virtually, but the biggest component is that we're here for you. And we want to try to expand our ability to connect with you when you may not be able to feel safe coming in, or when we really just need to get even a telephone interaction to know that you're doing okay and that your meds are working and that you are, not having issues where you're going to have to be readmitted or get to the point where, it's so severe that the condition of that patient really deteriorates. And so I think it's, just telling the story that, we're here to provide quality care to you in whatever manner that is. And that certainly, it's a little bit scary, frankly, for patients to adapt to some of that. This is completely different than what they probably grew up in, especially in our rural communities where they may have had a family provider they saw for their whole life. And now you're asking them to get on a phone and talk to somebody. And I think patients worry sometimes about losing the connectability or the real emotion with a provider on the other end. But actually, I think you can convey your emotion just as much as you would for an in-person visit virtually. It's just how you set that tone. And so a lot of the focus was also trying to educate our providers on how do they make patients feel comfortable so that this isn't an awkward experience for the patient. It feels just like they would be face-to-face in clinic, with obviously the limitation that they're not. And then training our staff too, to really explain to the patient and educate them that this is how this is going to work. And we're going to be here to support you every step of the way. And, you can call us if you have questions and we'll try to help troubleshoot as best as we can. So I think it's establishing that relationship early on and letting the patient know that while this is different and we understand that, we're here to, continue to provide quality care, whether that's virtual or in person.
Did your providers have to go to their clients or offices to run their telehealth clinics, or could they initiate them from home?
We actually had a lot that did both. We had some folks that were in our clinics that actually would come in and see almost like a full day schedule, but from the office. And then we also had some folks that did this from home. The great thing about the regulations that came out was there wasn't really geographic parameters on where we could practice that, as long as our billing and our coding were really good to ensure that they were stating where the patient and the provider were when they were having those interactions. So we saw a mixture. As we've gone forward, we'll certainly want this to be more a part of our normal clinic practice. And so how do you have, maybe dedicated time for virtual in the morning and maybe, or in the afternoon, where really a provider is spending part of their clinic time actually conducting virtual care in our clinic versus being at home or doing it on administrative time, just so that we can include some of the efficiencies around providing more access within our clinic settings. I think that's a big goal for us, is how do we use virtual care for some of our follow-ups that we know don't take a long period of time to really help facilitate creating more net new access for patients that may need to get in to really be seen in person. And I am very close to getting this this telehealth dashboard up for you all, and hopefully I can share it here. Sometimes it takes a minute to load in here. And I will try to make it as big as possible here. So, one sec here. So we have this so that you can actually filter by different department to see their impact directly and their patients based off of the demographics we have. But I'm just going to select all so that we can kind of show you from a large scale the impact there. I'm not a big fan of Internet Explorer, and for some reason it's very slow with this, so hopefully we can get it. So I don't know if you guys can see that. Hopefully you can. And let me see if I can kind of zoom in. So right here, and hopefully you guys can see this. I know that, let's see if this makes it a little bit bigger for you. We have certain metrics. Are you guys able to see that? I just want to make sure. Can someone give me I can't see everybody on the side. So can someone just give me a yes?
We can see it, and it looks as awesome as Internet Explorer will allow it to look.
Okay, great. So as you can see at the bottom, so this isn't the most accurate up to date. This was just our metrics through May. We've actually done, again, 47,000 interactions, and it doesn't include our American Well platform information, but this is from our ambulatory clinics. And as you can see across here, we've got our total miles avoided for our patients, and you can actually hover over, different counties to see the unique patients that were arrived virtually for that specific location. So obviously here in Boone, we have it's the darkest because that's where we're located. And certainly a lot of our patients still do virtual visits even when they live close. And so the miles avoided is really nice because it's actually a metric that we can utilize to kind of talk to our patients about what we're doing for them and the benefits for them doing a virtual encounter. And then you can also see visits. I'm sure it's kind of small, but you can see here our family medicine, neurology, our child and adolescent psychiatry departments, bariatrics, cardiology, all of those that are doing virtual visits and the amount. And then we also have arrive visits by hour, which of course you would expect to be between 8 and 5 because we typically hold these within business hours. You can see arrive visits by the weekday, which is also just a nice statistic to have. But I think the arrived by visits age group is probably the most telling story of all this, is that really our largest number of users from a virtual, and that could include telephone or Zoom or other types of virtual care, is our 50 to 64 age group, closely followed by our 65 to 85, which is so surprising to me based off of what you would expect for users that have probably technological abilities, but certainly indicates too that this is not a limiting factor based off of age. So I think that's great. And then we do have no-show rate, and this is just based off of some of the interactions that we've had. So you can see that this is a specific no-show rate based off of virtual care. And it was surprising actually during COVID when we did a large amount of visits. I think in April, we did about 19,000 visits virtually, which was significant. We had a pretty low no-show rate. So that's also great compared to the number of visits that occurred.
That's an excellent tool.
Yes, it's great. And I would highly recommend anybody who is working for a health system, who is working towards trying to track and be able to have really useful data to work on creating some type of dashboard like that. We have a wonderful group that puts dashboards together for all different types of clinics throughout our system. So I can't take credit for that, except for the fact that that was something that I had specific parameters of what I wanted included, but certainly wasn't the one behind making it. So, I think it's a great thing to have, and it's a real, it's big in the sense that when you're trying to convey to your health system that this, is a priority and this is a valued program, having that data to support it is, at least in our system, a huge benefit to getting more funding or more opportunities to provide virtual care.
Well, we've got some more questions rolling in for you, Carey. The next one is, was it difficult to coordinate your scheduling, department, and registration areas when you switched to more virtual care? In other words, did your workflow change?
Yeah.
Virtual care?
Yeah, we created workflows for the PSR, for the nurse, for the provider. We had specific protocols and responsibilities for those that were involved. So a lot of our PSRs are the ones, patient service reps, are the ones who actually communicate with the patient. So they are in charge of making sure that the notice of privacy practices, the consent for treatment is going to their portal account or utilizing a resource account to get that to the patient via email, as well as making sure that for a lot of the interactions that occurred via Zoom, that they had the right meeting ID to be able to join that meeting when it was appropriate. So we had a lot of our providers actually had to delegate through Zoom, which was something we learned that was new, how to be able to schedule on behalf of the provider, because we were running into some barriers initially where you couldn't be in two places at once if you were the host. So if I'm scheduling for patient A at 8 a.m., but my provider B has another patient at 8 a.m., we had conflicts with both patients trying to see that provider. And so we had to delegate a lot of that under staff accounts and utilize different ways so that we could be creative in being able to expand the number of visits we could offer at a certain time. And so certainly a lot of training. We actually do have a communication center that does handle about 20 of our clinics from a scheduling perspective. And so they did a lot of training as well. And we had, again, I think it's important to engage the right folks, make sure you're including the right stakeholders so that they're buy-in and making sure that they're communicating that down to those that are actually connecting with the patients or going through those workflows. The nurse for us in an academic institute, you know, they do a lot of the medical reconciliation. And so we had to make sure they were a part of that Zoom visit to connect with the patient and talk to the patient to make sure that they were taking the medications or not taking the right medications and do that reconciliation within our system. So they had a separate workflow that they had to go through with connecting. And then of course we utilize a lot of fellows and residents throughout our, you know, practice on a normal basis. And so getting them to be a part of those Zoom conversations and then getting the provider on. So there was a lot of coordination, a lot of folks that had to be involved. But we, again, did a lot to try to frame that out so that there were specific roles and responsibilities identified for those different users.
Next question for you. We know that Missouri Work has a senior medical director, Dr. Karen Edison, but does MU Healthcare have a telehealth medical director, and who would that be?
They don't currently. That is something I've been pushing for quite a while, to get a medical dyad to really focus in. I will say this though, we have very strong physician champions in multiple areas that guide and really help influence the different areas. So our emergency medicine, oh, I'm going to get that wrong. Let me think here. He's not the medical director, but the chair of our medical department for the emergency medicines, is a huge supporter and sees such value in virtual care and what they can do to expand tele-EMS to some of our community hospitals, as well as utilize his groups to really provide some of those virtual urgent care interactions with patients. And so he would be one huge champion of really that facet of virtual care. But when you think about, again, virtual care is such a broad area, you really have to think about somebody who's also engaged from the EMR and the technology side of it. So we've got a great person who works actually in collaboration with Cerner out of Kansas City. We have what's called the Tiger Institute, which is a unique partnership between MU and Cerner. And so this homegrown department that we have a great physician, Dr. Thomas Selva, who does a lot of great work. So not only is he a pediatrician and does his own Zoom visits, but he also knows and understands our technological side of things. So I would say, while we don't have a specific person tied to it, we do have a lot of champions from various areas, whether it's inpatient, outpatient, emergency medicine, that really help us push forward. And we do have a steering committee team. And I would say that is a huge also component to have if you're trying to start or utilizing a virtual care program, getting the right stakeholders to be at the table to help push forward. And Rachel's a part of that and has, again, been a great resource to us in learning for, you know, what's going on in the landscape throughout Missouri from a regulatory and from just her historical presence with the state. But we've got, you know, finance, and we've got compliance, we've got legal, we've got marketing, we've got, I mean, you have to think about the whole gamut of folks that are involved in helping you promote as well as provide the care to patients.
Thank you. And you actually answered two questions in your response there. So we'll skip to the next one, which is, how did patients get the reminders for the virtual visits?
Yeah, and so again, we send it through our portal for the most part. A lot of our patients utilize our portal, which is great, and already had a portal account set up so they can receive an email with that link and information. We try to use it through the portal because we want to make sure that we're using as much protection around privacy and sending that to the direct patient and not sending it out. We don't want anything posted on social media or getting into the wrong hands where a patient might have someone else drop into their visit. And vice versa, we don't want patients getting into, some of our provider appointments that may not be the right one. So it's very important to make sure that the patient gets that and it's the accurate meeting ID. We've had a couple of mishaps where, a patient may be one off of trying to get the right meeting ID. So certainly trying to educate, again, the patients and the staff on how to accurately get that information entered. And then again, if we do have patients that don't have a portal access, we use a resource account. So on behalf of a department or a clinic to send that information via email directly to the patient. And the resource account really is developed so that our patients don't have access to our staff's emails personally. We want to protect our staff just as much as we want to protect our patients' privacy. So that's something we've utilized when we don't have an option to use a portal account.
Thank you. How did you let your patient community know about the availability of telehealth visits during COVID-19?
Yeah, so we did a lot of, we did some press releases and actually got picked up in Kansas City and St. Louis, I believe, regarding our free COVID visits that we were offering, because again, that wasn't limited to Boone County or any of our 25 county area that we serve. We wanted anybody who, needed to access that to be able to. Of course, lots of our Kansas City and St. Louis folks that have, a lot of the facilities out there did their own COVID response as well. So I think as a state, we did really good at covering the ability to have access to certain, services during COVID, specific to drive-through testing and of course, virtual care to kind of pre-screen. Our intention was that we just didn't want folks walk into our ED and expose people without knowing that they may or may not have COVID. And so really it was to protect the community, and we used that as a way to offer it. We thought about charging, and I think we ended up actually initially going out with a $10 charge and realizing that no, this is really our responsibility as a health system to provide good care, and we're going to offer that for free so that really we protect the our patients, our staff, and really anybody who may need access to this. And so we couldn't offer it long term, because certainly there's a lot of cost to put that up, but did for about 2.5 months have those available, and again did about 3,100 visits. So.
Wow. To your knowledge, have hospitalizations increased the past couple of months due to people not attending their routine checkups?
I don't know if I know that data, to be quite honest. I know we have a lot of folks coming back to our system now in person, which certainly is a good thing, but certainly we're cautious and trying to figure out, again, pointing patients to the right place of care at the right time. So understanding that if they've got a respiratory or upper, kind of condition, sinus, we want them to get pre-screened before they come. And we still have ways to identify that, whether that's the drive-through testing or, making sure that we're offering virtual care, when we can to them. So I don't know if I could speak to that. That would probably be somebody more on our command center that would know that, but good question.
How did you handle out-of-state patients with regard to restrictions for providers?
Yeah, and so we had to take that kind of case by case, but certainly it was our intention, that unless we have an established relationship with that patient and that we are looking into making sure that we have the ability to provide, there was a lot of, regulations that kind of were flexible during COVID related to providing across states, but for the most part, we encourage our providers to just do only in-state follow-up visits and new establishment of patients, unless there was special permission, or a one-off case on following that patient where they may have been. Certainly a little bit of a challenge for us, thinking about going forward, not even COVID, when we have a large group of our, being a university where we have lots of students, how do we help them when they may go home? To keep, in touch with them virtually. So I think that'll become a bigger issue for our system and something we need to consider, down the road is how do we, and hopefully, in the near future become part of the compact licensure, ability to provide care across states for our providers, and that would be a great addition to get Missouri through that. But, with any legislation, things take time. And so we certainly just want to make sure we're being cautious of that until we've got, approval to do that.
Are the visits recorded and stored in the patient charts?
They're not. No, we don't record the Zoom visits and we don't store them because Zoom and our EMR don't communicate. They're not, connected through an interface. We just document the encounter, but we do make sure that we do provide consent and obtain consent from the patient prior to their visit. And we document that we obtain that consent within the patient's record.
And is this technology primarily being used for acute concerns or also chronic condition management?
Both. Yeah, we've got a lot of focus just really on any type of condition that we can treat virtually. I would say, just as much as our follow-ups for regular conditions, we want to be able to offer virtual check-ins with our chronic care patients because, cardiology, diabetes, some of those ones where if we don't have those added touch points or frequent, ability to treat them, they tend to be the ones that end up being readmitted or have conditions that then they get to the point where, that type of interaction is not really meaningful. They're back in our system and probably as an inpatient. So we certainly are trying to keep in touch with multiple different types of patient acuity.
Thank you. This next question refers to your dashboard that you showed us earlier. In reference to this statistics you showed previously, what type of patients are you classifying as unique patients in your arrived visits and unique patients by year and month graph? Are the unique patients telehealth visits?
So unique patients, so when we, for our specific dashboard, that's all virtual care. And so my understanding is our unique patients are patients that have not had a virtual, or they're the first time they've had a virtual interaction with us. And so some of our patients are having multiple virtual interactions throughout the course of, their treatment. And so the unique is the first encounter that patient has from a virtual visit, where our total number of virtual visits includes those that may or may not have had multiple visits.
Perfect, thank you. Did you create patient education materials about telehealth visits?
Yes, yeah. So we did a lot of education and we created, we actually have a dedicated web page on our site that's specific to video visits or virtual care, I should say, that has some of our for patients to download. It's got a video on how to download Zoom and how they'll receive their information. It's also got a document that they can click on that links out so that it follows instructions step by step for them. But we also created internal documents for our providers and staff on their portion as well. And we held a lot of trainings.
Perfect, and I've got one final question for you. What would be your recommendation for Fqhcs expanding to virtual care?
Say that one more time.
What would be your recommendation for Fqhcs expanding to virtual care?
So I'm assuming this is somebody who is working at an FA or a
Fqhc, Federally Qualified Health Center.
Yeah. So talking about expanding from their perspective, I assume.
Yes.
Okay, so I think the biggest thing you need to do if you're starting out fresh is, again, find the right people to be at the table to have those internal discussions right off the bat. So understanding and getting that buy-in, find a physician champion. That's huge, whether they're official medical dyad or whether they're just a physician champion by nature. Having a physician support from the clinical side is huge. You need somebody to be the advocate so that your providers are willing and wanting to provide that care, because you can set up technology anywhere and you can do all the workflows and all the trainings, but if you don't have the providers and the staff to engage to provide that, then it's really pointless. And I hate saying that because certainly we want all of the aspects that go into it to be valued, but certainly the ones that are providing the care and for the patients that need to receive it, you got to have that buy-in up front, and you got to have that buy-in from leadership. And we're still working on that. I think COVID really proved that we have a place for virtual care in our system. But prior to that, again, it was more of this added ability or luxury that we provided to patients. It wasn't really a part of our care delivery plan. And so going forward, making sure that you strategically figure out how to engage those leaders to make sure that they're aware. And then working to identify whether it's federal funded or donor funded so that you have the technology and the support you need to facilitate it is huge. You know, we continue to look at opportunities for grants and other ways to fund it because virtual care is not cheap, unfortunately. You know, there's a lot of technological parts that go to it, devices, partnerships, broadband, you know, connectivity. It just depends on what you're doing. And so certainly, you know, just need to think through some of those, you know, those processes and get a team together to kind of help identify what you need. But yeah, physician support's huge. Getting administrative or leadership buy-in is huge. And then just having faith that what you go out with and what you try is not always going to be the right thing off the front, but you're going to work with it. And when things like pandemics come up, you're just a little bit more prepared to help your system figure out what to do and how to leverage it. So, you know, it takes a lot of time and practice, but you know, use the resources you have, use this Echo, and use the people that you make connections with. I've learned so much in my limited time of being in this through connecting with others and inspiring to look at, you know, some of these, you know, huge institutions like Intermountain and Cleveland Clinic that have been doing this and really capitalizing on it for years and trying to adapt to figuring out what we can do on our own scale and figuring out what that means for us internally. So I'm always happy to be a connection to if anyone wants to reach out and talk one-on-one. I've been there. I did not have a background in virtual care or telehealth coming out of a fellowship program. I was given a project and told this is what we need and learned as I went. And so certainly am not an expert by any means, but certainly have learned a lot and I'm always happy to connect. So.
Well, thank you, Carey. This has been a wonderful question and answer series. We've learned lots from you, and we really appreciate the fact that you're offering your services to continue to answer questions. So thank you so much, Carey. It is 10 o'clock, folks, so we're going to let you go, but join us next week. And I believe the topic is school health and telehealth. So thank you, and we'll see you next week.
Thanks,
Bye.
Carey.